All right, friends, here we go. So, most recently in ethics in medicine, we've been talking about healthcare costs and healthcare as a right, and how we understand it, and how Robert Nozick and John Rawls would interpret it. And we can see how even the people who want to ensconce healthcare as a right recognize that it can't be an absolute right. It has to be constrained by costs, by containment, by what's a realistic right, by what's an excessive draw upon resources, and how you find that balance. So let's say you work in the healthcare field. You're the head of a hospital. You have to figure out where resources should be delegated and to who. Let's say you have only a certain number of possible heart or lung or eye transplants. Who should, or kidney, or whatever, who should get priority? Should it go to the first person to sign up? Should it go to the person with the healthiest body? Should it go to the person who's contributed the most to society, who's like an innovator and a whatever? Should it go to the mom of 6 children, right? How should we allocate these resources? And so, in one of the articles I had us read for class called Principles for Allocation of Scarce Medical Interventions, they offer these 8 examples up of different ways of allocating, trying to, what's fair, what's just, resources. And were we in class, I would have us come up and rank them on the board in what order we thought should have the greatest priority. We see lottery seems like a pretty fair assessment. You just, randomly put your number in, pull it out. You can see the uses here for military draft, schools, vaccinations. Not all vaccinations, as you'll see with pandemics. You also see first come, first serve. I mean, you can see the drawbacks and the advantages to this. It doesn't matter if you're a king or a pauper. Uh, Depending on what time you come, first in time is first in law, right? You see this used with ICU beds and as well as part of some organ allocation. Uh, we have a principle in our country which runs pretty thick in the medical establishment, which is taking care of the weakest among us, right? It's interesting that all systems of justice in the world, in the animal kingdom, have a might is right, with few exceptions. Whereas, like, literally every advanced human civilization has an idea of protecting the weak against the strong. Very interesting, and something for another day. But in the medical profession, you have the idea that, well, if you have 10 people to treat, you treat the person who's sickest, right? Who's closest to death. And that's a great good, right? However, it's an extreme use of resources, and in some catastrophes, you have to triage and leave the sickest person who you might be able to save their life if you invest all of your time and resources, but 5 other people with moderate injuries will get worse or die, right? You have youngest first, again, with this, like, we should help the most innocent and weak among us. Used in the pandemic flu proposals, right? We want to treat those who are like most at risk, right? Classic utilitarian arguments: the number of lives saved, uh, prognosis or life years saved. So if it's between, you have to decide between giving a shot to a 20-year-old and a 65-year-old. Well, who's going to benefit most afterward, based on amount of years of life lived, right? And we'll see that we even get this adjusted, what was called the quality adjusted life years, where they sort of measure the value you get from those years of living, right? Which is a very interesting thing. We'll get to it in a minute. We have the instrumental value. Uh, Basically, like, if you're of great impact or importance, and you'll see I found a little thing on how they're allocating resources during COVID, and it's very similar that you're going to give priority of those things to certain crucial members of the crisis. And finally, the reciprocity principle, which says that if you've given an organ, you should get priority on getting an organ in the future, right? Or if you're family. And so these are some pretty interesting things. I wish we had could do it in class and sort of walk through them, but we're going to bounce to the book. Okay, reading from our book, page 160. Ezekiel Emanuel notes that rationing decisions occur at all levels of the healthcare system. In addition to macro-level decisions regarding how to allocate scarce financial resources, there are a variety of localized contexts in which policies have to be crafted for allocating vaccines, ventilators, transplant organs, and other specific health resources when not everyone can receive the care they need. Cursed, Wertheimer, and Emanuel describe a variety of principles that might be used to ration care. Some of these rose to national prominence in 2009 when the emergence of the H1N1 influenza pandemic thrust the need to ration vaccines and ventilators onto the public state. Boy, if they could update this article. Huh? The CDC estimates that there were 1 million cases of H1N1 in the United States alone, although cases had been reported in every state by the summer of that year. Safe and effective vaccines were not available until the end of the year. During normal or inter-pandemic flu seasons, CDC guidelines indicate that the very young and the very old should be given priority access to the annual flu vaccine. This strategy is supported by a principle that gives priority to those who are most vulnerable. Right? Makes sense? Limited supply, give it to the elderly and the young. Why? Weakened immune systems. As opposed to those robust souls in the middle of their life. Ruha us. But this may not be an appropriate strategy in the face of an outbreak like the 1918 Spanish flu, which killed 500,000 Americans and is estimated to have killed as many as 50 million people worldwide. A pandemic with such high mortality rates could effectively send the country's social and economic infrastructure into disarray. Yeah, right, people would say. In this case, it may actually be self-defeating to allocate scarce doses of a vaccine to the very old and the very young. I would pause this in class and say, why do you think it would be smarter to not allocate it to the old and the young in an extreme pandemic? Well, that's right, since these populations depend heavily on care from persons in other age categories. If those caregivers are felled in large numbers, similar to like COVID, the social supports on which the old and the young depend might collapse. For this reason, it might make sense to give priority to those in their prime for whom the vaccine is most likely to have a beneficial effect. Such a strategy is supported by a principle of maximizing the medical benefit of a scarce medical resource. But if quantities of the vaccine are severely limited, as surely will be for most of the first year of an outbreak, then such a strategy may be too diffuse. That is, it may make sense to give priority to personnel who play essential roles within society's basic health and social infrastructure. This would give priority to first responders, such as police, paramedics, physicians, and public health workers, as well as to other government employees. Such an allocation scheme would be supported by a kind of social triage principle according to which, when not all can be saved, those who play the most important role in keeping the social infrastructure of the community functioning should be saved first. And so, unfortunately, unlike any other time I've taught this class, we get to apply or see how these principles are applied in live time to a pandemic unlike anything we have ever seen, or so it seems. Who gets health resources in a COVID-19 pandemic? I'll try to attach this article in the notes, otherwise you can probably find it if you're clever. These ethical values, maximizing benefits, treating equally, promoting and rewarding instrumental value, and giving priority to the worst off, yield 6 specific recommendations for allocating medical resources in a COVID pandemic. Maximize benefits, prioritize health workers, do not allocate on a first come, first served basis. You should ask yourself why not. Be responsive to evidence, recognize research participation, and apply the same principles to all COVID and non-COVID patients. So they say the value of maximizing benefits is most important. And here I will read a section of this, and you can just see if it squares with your intuition or not. It probably does. Operationalizing the value of maximizing benefits means that people who are sick but could recover if treated are given priority over those who are unlikely to recover if treated, and those who are likely to recover without treatment. Because young, severely ill patients will often comprise most of those who are sick but could recover with treatment, this operationalization also has the effect of giving priority to those who are worse off in the sense of being at risk of dying young and not having a full life. Because maximizing benefits is paramount in a pandemic, very utilitarian, we believe that removing a patient from a ventilator or an ICU bed to provide it to others in need is also justifiable, and that patients should be made aware of this possibility at admission. Undoubtedly, withdrawing ventilators or ICU support from patients who arrived earlier to save those with better prognosis will be extremely psychologically traumatic for clinicians. Oh, for the clinicians? And some clinicians might refuse to do so. However, many guidelines agree that the decision to withdraw a scarce resource to save others is not an act of killing and does not require the patient's consent. I will let you to decide if you agree with that or not. We agree with these guidelines that it is the ethical thing to do. Initially allocating beds and ventilators according to the principle of maximizing benefits could help reduce the need for withdrawal. Recommendation 2, like we see in our book, critical interventions, testing, PPP, PPE, ICU beds, ventilators, therapeutics, and vaccines should go first to frontline healthcare workers and others who care for ill patients and who keep critical infrastructure operating, particularly workers who face a high risk of infection and whose training makes them difficult to replace. These workers should be given priority not because they're somehow more worthy, but because of their instrumental value. They are essential to pandemic response. If physicians and nurses are incapacitated, all patients, not just those with COVID, will suffer greater mortality and years of life lost. Whether health workers who need ventilators will be able to return to work is uncertain, but giving them priority for ventilators recognizes their assumption of the high risk of work of saving others and may also discourage absenteeism. Priority for critical workers must not be abused by prioritizing wealthy or famous persons or the politically powerful above first responders and medical staff. Oh, of course not. It's never happened. It's never happened. You've never seen that sort of thing where celebrities or politicians are getting tests when even the doctors in the front line aren't being tested. I've never. Have you? Okay, it's late in my day. I'll rein it in here. Okay, I don't want to read all of this, but you can see that in an ideal world, we might like to prioritize the poor, the elderly, the weak, the impoverished. But it's interesting how our values and our ethics, at least in some situations, change when it gets real critical that those with the most social worth in a pandemic, like, Maddie, uh, or, they get priority treatment over the billionaires, over Jeff Bezos, over Bill Gates, right? Like, it's the people who are on the ground floor. Uh, and healthy ones even over the elderly who might not make it, right? Sucks, but if we let the people who are taking care of the most of us suffer, everything trickles down. So, long-winded bit. Okay, friends, so the last thing I want to talk about in this video are the quality adjusted life years. And so the idea behind this is when the hospital is looking at who should we treat, they look at the prognosis. What's the quality of life going to be after the treatment? And so the idea is if you're 40 and the average person lives to be 75, you have all of your faculties, your body doesn't work, and you're getting maybe an eye replacement or a hip replacement. For each normal year of life of normal health, you're going to get 1.0. Now, they detract based on what your disability or impairment is. So here you can see if you're blind, even if you're 40, your quality is going to be 0.5. So even if you have an expected another 35 more years of living, really that's going to be 17 and a half according to the quality, because they say, okay, well, we give the hip replacement, but a blind person doesn't have the same quality of life and range of motion and ability and normal range of functioning that the healthy person does. And same with a person in a wheelchair, I believe it's zero point 0.5, but they've got a measurement of like, to what extent are you impaired in your daily functioning? To what extent can you get up, clean yourself, take care of yourself, travel, cook, or to what extent are you impaired and suffer? And it has a lot of benefits. It makes people take into consideration that they're allocating resources in a way that will be most utilized, right? But it does seem very unfair to people who are blind or handicapped or have certain health impairments or conditions or disabilities that, according to the quality measurement, gives them less value, right? And you get into this question of like, well, who are you to determine what type of a life has more value or less value, right? Um, and things of that nature. And this spawns all sorts of wild, conversations about what is an ideal life and how can we measure that, and eugenics, and what happens if a person feels like they would be happier with a limb of theirs cut off, or someone who like decides that even though they're born being able to see, they would feel more themselves if they were blind. And I kid you not, there is a body identity integrity disorder condition. And I mean, I'll give actually a really cool case study on this, on assisted reproduction and the principle of no harm. And I'll be fascinated to see what people see. But you can see how it kind of comes out of this conversation of quality adjusted life years. Can we measure quality of one life versus another's? We'll see next week when we look at the case for Dax Cohort and Mary Northern, that uh, Dax didn't think he had high quality of life once he was in an injury, and took him a while to get used to life as a person with a disability and adjust to that and find meaning and value. And so it raises a lot of really core questions of how do we judge things? What is a valuable life? Can we compare one life for another versus another? Things like that. So thanks for sticking with me. I think we did pretty well, and I will see you on the other side.